More than gastroenteritis. A case of Coxsackie B6. Coxsackie B6 is an enterovirus of the picornavirus family and causes infections with a wide variety of symptoms. However, most cases are generally mild with a self-limiting illness. The patient I'm going to talk about is a 56-year-old female with a past history of type 2 diabetes and a left bundle branch block, who presented to our emergency department with profuse watery diarrhea, nausea, high-grade fever, cough, and pleurodynia, which were all present for about a week prior to admission. On presentation, the physical exam showed mild bilateral mid to basal crackles and generalized abdominal tenderness. The labs revealed leukocytosis with lactic acidosis, and a rapid SARS-CoV-2 testing was negative. The chest X-ray revealed possible senescent changes with diffuse prominence of interstitial markings. CT abdomen and pelvis showed colitis with mesenteric and perirectal lymphadenopathy. Given the imaging findings and the presentation, a diagnosis of sepsis secondary to colitis and atypical pneumonia was made, and the patient was started on Levaquin and IV fluids. Later that same day, she developed acute hypoxic respiratory failure with saturations in the low 70s. She was non-responsive to the BiPAP and was consequently intubated and transferred to the ICU. In the ICU, the patient was persistently tachycardic with a 12-lead EKG showing SVT and was given 3 doses of adenosine, which failed to convert the rhythm, as a result of which synchronized cardioversion was done. She was also noted to be hypotensive and was started on Levophed. Given the acute desaturation, there was a concern for COVID pneumonia and a repeat SARS-CoV testing was sent out. The test was repeated twice and returned negative on both times. At this point, an echocardiogram was done which revealed severe global hypokinesis with an EF of 15%. Significant because on a previous echo done about 8 months prior, the EF was noted to be 55%. Due to this, a diagnosis of fulminant myocarditis with cardiogenic shock was made, leading to multi-organ dysfunction, acute kidney injury, as well as transaminitis. Aggressive diuresis was started with the Lasix drip, and MAP was maintained above 65 with the help of pressors. Gradually, the FiO2 requirements decreased and the patient was extubated, initially to the BiPAP and then weaned off to oxygen. She was also gradually weaned off of pressors, however, remained on the Lasix drip. The post-extubation period was complicated by some ICU delirium, however, the patient responded very well to frequent reorientation. She was gradually transferred to the general medical floor, taken off the Lasix drip, switched to PO Lasix, and once she was stable, she underwent a cardiac cath. The cath showed stable coronary artery disease with improvement in EF to 30%. However, the LV and RV remained significantly dilated. The patient was started on PO Lasix once the diet was resumed, and then she was discharged to acute rehab. The aim was to discharge back home once sufficiently rehabilitated. A day prior to discharge, the viral panels returned, which showed increased Coxsackie B6 antibody titers, and the diagnosis of Coxsackie B6 myocarditis was made. At a 1-year follow-up, the patient presented with improved functional capacity with minimal symptoms, and the repeat echocardiogram showed an EF improved to about 45%. This case is significant because it shows that Coxsackie B6, even though primarily known to cause gastroenteritis, can cause severe multisystem disease in previously healthy adults, including severe myocardial compromise. Recognition of the cardiac compromise is critical and time-sensitive, and any delay in diagnosis can cause dire consequences. Thank you.